some machinery, heavy machinery working outside, just mind that. Be careful if emergencies or if you need to step out of the room. Appointed of co-opted members. This is a formality. The co-opting of the 8 board members for this meeting, the formal constitutional change for the membership of the board for Peterborough will take place on the 27th of July, and these board members will become officially members. Yes, please.
Sorry, it's just a formality. So we are going to co-opt these board members just for today, but as Councillor Navarro said, 27th of July will be the board meeting where these members will become official members. So these are Stephen Taylor, Martin Purbuck, Paul Mead, Pam Green, Dorothy Gregson, Dr. Neil Modhar, John Roke and Erin Lilly.
Thank you very much. Does the board agree to these appointments? I guess so. Okay, thank you. We're now going to move onto the formal agenda for the meeting. Any apologies? Yeah, apologies for absence. Kisia, Senior Democratic Service Officer, can you please let us know?
Thank you, Councillor Navarro. So we've had apologies from Councillor Anne Shahid and Councillor Neil Boyce is here in her place. We've had apologies from John Gregg. We've had apologies from Patrick Warren Higg. We've had apologies from Jonathan Jelly. We've had apologies from Andrea Wood, and Tim Dare is in her place. We've also had apologies from Dr. Jag, apologies Hawalia, and we've also had apologies from Linda Thompson and Dr. Zoe Hutchinson. Oh, and Kate Parker and Adrian Chapman. Thank you.
Okay, thank you, Kissy. Item 2 is approval of the minutes of the joint Cambridgeshire and Peterborough Health and Wellbeing Board and Integrated Care Partnership meeting held on the 20th of March 2026. The minutes can be found on pages 3 to 14 of the package that was sent to you, the pack that was sent to you. Dr. Mike Napton sent apologies to the previous meeting that were not recorded in the minutes, and these should be amended. We are being asked to approve the minutes of the joint Cambridgeshire and Peterborough Health and Wellbeing Board Integrated Care Partnership meeting held on the 20th of March 2026 as an accurate record. If any member does not agree, would you raise your hand now, please? Thank you. I take that as approved. Item 2 is the action log. That's right. We have been asked to review the action log from the previous meeting. The log can be found in pages 15 to 20. Do members of the board have any comments to the action log? I do. No comments to the action log. I think I did have some comments to the action log, but let me just find them. Now we'll touch on some of those as the meeting goes and progresses. So I'll come back to them as the meeting is in progress. If there is no further comments, we are content to note the action log. Casey, can you please note that the item is logged? Thank you very much. Item 3 is the fourth quarter of the BCF full year progress report for 2025-26 and the future plans for 27-28. This item can be found on pages 21 to 112 of the agenda. Pam Green, Director of the Neighborhood Health, Places and Partnership of the ICB, please, can you introduce the report?
No,
It's not Pam. It's Pam, isn't it? Isn't she? Yeah.
Pam, are you presenting?
Are you?
No, Lisa is.
Lisa.
Sorry, Lisa. Thank you.
Good morning, everyone. Thank you very much, Chair. The Q4 Better Care Fund submission, and just before I go into that, apologies from Caroline Townsend from Cambridgeshire. She's had a very last minute bad news and she's had to leave work, so I'm going to present for Cambridgeshire as well. In terms of the Q4 report, both Cambridgeshire and Peterborough have similar positions in respect of the metrics and achieving those metrics. So taking emergency admissions to hospital and discharge delays, both of those metrics for Cambridgeshire and Peterborough are not on track. We're not on track to meet the goal at the points that we submitted. And the admissions to residential and nursing homes for Cambridgeshire and Peterborough are both on track. So in respect of those that are not on track, the emergency admissions to hospital for people aged 65 plus, there has been some investigation into the reasons behind that, and they are, as you imagine, very complex. But there is an indication that there's an underutilisation of community urgent care services. Whilst available capacity has been promoted, that still remains a situation and opportunity. In terms of discharge delays, the indication there is that demand for some areas have exceeded capacity for Cambridgeshire, but there are some concerns certainly for Peterborough in respect of the quality of the data, which therefore makes it less reliable. You could be reassured that there is work underway to endeavour to resolve both of those components. And in relation to the plan for 26-27, this current year, we have submitted those plans, and these particular components, emergency admissions and discharge delays for Cambridgeshire and emergency admissions for Peterborough, remain a cause for concern in terms of doing a deeper dive and giving greater insurance in terms of those plans submission. So it is a focus for us. I think it's really positive that as a system we've got some improved governance, we've got some improved collaboration in terms of seeking to achieve those targets, and a commitment to unpicking and determining what we can do better together to resolve them. And that is a real focus for 26-27 as part of our Better Care Fund governance. I'm going to pause for questions.
Any questions from anyone?
It's not a question, but it's a collaborative support statement to Lisa and Caroline that isn't here. So the improved governance that Lisa referred to is working with health and our place partnerships to ensure that we address the variation that you've talked about. I think we've strengthened the governance with local authority partners, and this year is nationally defined as a review year. So going into 26-27, we were bringing back to the Health and Wellbeing Board the areas of change and improvement that align to our neighbourhood health plan, because the Better Care Fund between us funds a substantial amount of our integrated discharge teams and our neighbourhood resources. So it must be viewed in that context. Thank you, Mr. Chairman.
Thank you, Pam. Please, yes, well, Mike. Hi, Mike. Yes, please go ahead. The micro is working, Mike, I think. Press the middle, yep.
I'm so sorry. I'm Mike Napton. I'm representing Cambridge and Peterborough Foundation Trust. Can I ask a question? And I should probably know the answer, but when you talk about hospital admissions and delayed discharges, does that just relate to acute hospitals, or does it relate to all provider hospitals in the county of Peterborough and Cambridge?
The majority of the data that we're looking at here refers to acute hospitals, but we do know that from our mental health hospitals, there are issues with discharges, and there is a system plan to work on that as well.
So to be clear, it's not included in this data, but you are aware of the issues with regards to delayed discharge and emergency admissions in the context of mental health beds?
I think I personally am acutely aware of the issues in relation to mental health discharges. I will take that away and confirm exactly in terms of the data whether it includes mental health settings as well, and come back to you on that. But certainly I am acutely aware of the issues, and there is a plan with CPFT to work on that, certainly for Peterborough and hopefully for Cambridgeshire this year.
Much appreciated, thank you.
Thank you, Mike. Please.
Thank you. Just another question in terms of delayed discharges. I wonder if any data is available on readmission rates for those patients whose discharge is delayed by around 5 days or whatever.
There is data available on readmissions. Whether that drills down into those who are delayed and that correlation between a delay and readmission, I'm sure the data would be person. You could drill down by person. Whether that's a specific data set that's looked at globally, there is a piece of work called High Users, previously called High Users, but that does look at people who have frequent attendances into hospital, and there is a proactive piece of work around supporting them not to be readmitted. But I think maybe John and Pam may have something more to say.
Thank you. Go ahead, Ian.
Sorry, Steve, I don't think I can answer that one directly without looking at the data, but it's a good question in terms of what's the impact of the delays through someone's journey, and does that increase the chance of them being readmitted? We do track that information, but don't have it to hand. I was just going to emphasise the new governance has been put in place, and that sounds beautiful, but is it effective? Is it making a difference? One of the things we've recognised is we've got to have a stronger grip on some of the performance around the system. And while we've got some areas of really good practice, it's fair to say some of our discharge performance has got worse over the recent period and causes delay and in some cases harm to individuals caught up in that. So about a year ago, we talked about investing further resources into particularly our Pathway 1, which has taken a while to unlock. I'm very pleased now that Pam and the ICB have unlocked that funding, and that will now start flowing into new capacity from August, which will give us much needed support to help speed up discharge process, particularly in Pathway 1. People need support, ongoing support at home, usually therapy-led services. And in addition to that, that will also help support people who go into our community beds, our community sort of general healthcare beds, not our mental health beds, because they often get stuck at the end of their journey in community beds and need support through Pathway 1 as well. So action is being taken, and that governance is overseeing the implementation of that additional capacity, and we collectively need to be relentless in our focus in when is that coming on stream, what is interim capacity to support our current position, as well as what is a substantial increase in the capacity we have, particularly in those pathways to support vulnerable people. And I think as a Health and Wellbeing Board, we saw the intention of the plan about a year ago here, and I had the pleasure of presenting all the wonderful work we were going to do, but it's been heavily delayed. And I think we should take a clear focus on actually, is it having the impact we expected to in terms of people's journeys from hospital back safe into their community? And then to Steve's point, are we keeping them safe at home as a result of that, or are we ending up with readmissions that we could avoid? So new governance is in place. We will be overseeing investment and implementation of new capacity, which should make a difference, and we should track that here at the board, Chair.
Thank you very much. Any further questions? Yes, Pam, please.
Just to context that so that colleagues are aware what to look for to discharge what my colleague has just said. That reporting will come through the Neighbourhood Health Delivery Committee, so that you've got that line of sight between delivery our tactical unit, and this is a strategic board. So we will be able to give you that reporting.
Thank you, Pam. Yeah, that would be great because the figures are not encouraging, and I cannot see. I was going to ask which of the measures, the plans that we are putting out, those three would deliver the outcomes that we expect. But these three are all encompassing, and they couldn't work without each other. So yes, I think getting those figures and that data and that analysis would be extremely helpful to see whether what we are doing is effective or we need to do something different. Thank you. Thank you, Lisa, for the report.
Thank you.
Now, the Cambridgeshire and Peterborough Health and Wellbeing Board an integrated care partnership is being asked to formally approve the 2025 and 26 end-of-year NHS England submission. Note the final Better Care Fund 26-27 narrative and planning templates, and discuss an input into the future approach to alignment and neighbourhood health framework and future plans. Are we content to agree the recommendations? Okay. Thank you very much. We'll note that. That everybody in favour.
Is that everybody in favour? Sorry.
Yeah, nobody objects to
Yep,
that.
thank you.
That's right. Right. And probably on that point, just I wanted to mention, I mean, the Better Care Fund, but also the ICB and the plans that they have, and I know that our remit is to make sure that they are fulfilling our duties under Section 26 of the Health and Social Care Act of 2012. But we are supposed to have a view of those plans and the projects and the commissioning, and I'm not sure what we have done over a year that we have been here. So that is something that I would like to note and see whether we have to have an input in that and make comments to those commissioning plans.
Okay. So I'd like to bring Dorothy in, because what we've been working on together is a neighbourhood health delivery plans, well, the strategic plan, and then colleagues from Place have the delivery plans that sit under that. So it was a part of the first neighbourhood guidance that the Health and Wellbeing Board would sign that off. We are generating that currently, and whilst the national programme has stepped that sign-off down, we are still very committed to bringing that here, and that is work in progress currently. So we're working with public health colleagues, directors of adult social care, Place colleagues, voluntary sector, to ensure that we have got that constructed to reflect the communities and the challenge and the sensitivity of our population. And actually the way we've designed that has come out of this group's development group that we had in this very room. So I can assure you it's being developed in that way. And the joint commissioning opportunities that the Better Care Fund give us will also be featured through that. So I don't know whether any Dorothy or my local authority colleagues would like to come in on that.
Sally?
And Dorothy looked like
Oh,
she may want to come in. So
Sorry,
yeah, Dorothy would like to come in as well. But I was just going to add to that. So that's absolutely correct. And then the other bit that's part of the ICB plans is the Our Way strategy that's got the pillars of clinical areas that are focus priority areas for this coming period, which is reflected in the neighbourhood delivery plans and strategic plans, but is a standalone document as well. And I'm trying to remember if that's been part of the updates as the ICB has kind of come on board over the period when we've had updates from them previously. But if it's not come as a full document, then it potentially could alongside or as a part of the neighbourhood health plan that comes next time. And Dorothy, I can see you wanted to come in also.
Yes, Dorothy, sorry, I have you on my back, so I couldn't see. Please. We can hear you clearly, yes.
Excellent, thank you very much. So thanks for the question, and the commitment of achieving what you're saying is a joint one. What I would say is there's great cross membership between the committee I chair, which is seeking to move forward with the work we're doing jointly, so that there is that cross membership with DPH, the Director of Social Care, and the Vice Director of Children's Services too. So although it may seem distant from you, there's that jointness at that level. I think bringing our way here will be a really good mechanism, and I think when you read that, you will really see the crossover of the evidence base that we're all using the same one. And then the final issue, which panels are highlighting, that as we jointly work together through that group, understand what neighbourhoods mean for us, how we build on each other's strengths, that can come through the committee too. So I think it's been an issue of timing rather than anything else, and we look forward to the discussion here. Thank you.
Thank you very much for that, Dorothy. Good. Well, now we move on, and yes, I think it is important that we comply with our constitutional duty to be consulted and to respond to those commissioning duties of the ICB. Right. We move on to items number 4. That's correct. Performance and strategic obesity update. This item can be found on pages 113 to 160 of the agenda. Val Thomas and Damilola Ekinsler, please can you introduce the report?
Yes, thank you. Can everybody hear me? Is that okay? Right, good. Thank you, Chair. As you said, this is one of the priorities, the original 4 priorities within the Health and Wellbeing Board strategy. It sits within priority 2, the environment, and it was taken forward as a good example of the role that the environment can play in obesity. The report comprises of 2 elements. The appendix is a quite comprehensive overview of all the pertinent data. And then what we've done is pick out the key salient information and put that in the actual report itself, more as points for discussion. I think just of note is that the data is reported in different ways, like most things, and this is primarily, obesity data is usually reported at local authority level. Most of it is at upper tier level, but we do have some at lower tier level as well. And the paper also describes about the terms that are used as well in the document. If we go, first of all, go to page 115, which there's a chart that summarizes the 6 targets for the indicators that have been chosen. And I think you would say they're looking at it there that the main area of concern would be childhood obesity, which remains not on target and also a downward trend. And that relates to the levels of obesity in year 6, but also very much the inequalities gap, which we haven't seen any real shift.
And sorry, Val, to interrupt there, but on those graphics and that list there where the red bands are, those percentages are, if I compare that to the graphs that you have down in your report, those are the totals, right, of the population. So when you mention in number 1, reduced childhood to year 6, 40.9% in Peterborough, that is a total of population, right? From 100% population, or that is the target?
No, I think that is the current. The second column where you have the percentages in that, those are the percentages where they are at the moment, the percentage of children who are weighed and measured in year 6. If I go back a little step, the Child Weight Management Programme measures children annually in all maintained schools at reception and year 6. And that's taken as kind of the barometer of where we are with childhood obesity. And what we would be looking at here, as that barometer, we'd use the percentages in that year 6 as indicating the levels, whether we're going up and down in terms of obesity in the wider population.
Okay.
It's the indicator that we use because it's obviously we can't measure the whole population. So I think that inequality gap, I think that was where I was, is where we are with, I think, probably of some concern. With regard to the excess weight in adults, as you see, Cambridgeshire is just about in the position of where we were before COVID, which is the ambition, and is actually just a little bit above it. And Peterborough is about the same, but unfortunately is on a downward trend. With regards to physical activity indicators, again, we just have the data for Cambridgeshire. The survey is collected nationally, so it was just the way they collected the data in these particular years. And we are seen as being roughly the same as our ambition and with an upward trend. However, with adults, I think it is a very good story in Peterborough, which is for physical activity, where they are above the target, and Cambridgeshire is about the same as the target. So it's a very mixed picture. I think we haven't really seen any great change, but I think probably the reds that sit aside children are probably the concerning element. If you go to, I think, page 116, there's some key points I think that are pertinent that give more sort of granular insight to the data. The high rates of obesity are very much associated with, and deprivation, and inequalities associated with deprivation, ethnicities, and gender, and it's a persistent pattern. And the other important factor is that children, when we measure children in reception class, that the rate doubles by the time they get to year 6. And that's a pattern that we've seen now. It's quite embedded. I think the other thing to be mindful of in terms of adult obesity in Cambridgeshire, although the overall rate looks as though we've stabilised, rates in Finland are still of concern and are still higher. And one other thing about the physical activity is that in both adults and children, rates are higher in males and females, and again linked with deprivation. So moving on to, I think, that sort of overall picture and some of the granular points within that overall picture, I think, briefly, I'd like to say that I think there has been an awful lot of work that's been undertaken by a range of organisations across the system. And I think that those are captured on page 123. And that relates very much to the Obesity Charter, which there's a paper coming at the next meeting about this. But that was something that the board approved and has been taken forward. And Dami and I have been working with different partners in the system. Since this work started with obesity, we've had the PLACE JSNA, which has really highlighted the environmental impact on obesity. And my colleague Sarah will be, I think, presenting the next paper where this environmental work and environmental factors will be explored, and it's seen as a development of this priority. I think in terms of what's happening at PLACE, neighbourhoods and communities is vast. We see all types of initiatives arising from local authorities and in partnership with the neighbourhood teams, but also local communities as well have started specific projects. And it's this support for communities, which the initial work that Dami and I have been doing with partners, particularly in the district, is having a focus on community work. Children and young people, there are a lot of strategic developments, perhaps badged best under the Best Start in Life, And it's making sure that we embed obesity into all those new initiatives, into the hubs and that vast array of developmental work that is underway. Another element to the obesity work is more around secondary prevention, that early identification of people at risk and making the appropriate intervention. And there have been numerous programs very much working with the ICB, and ICB-led, but we've worked in partnership with them in public health. And that sort of ongoing development, as the new ICB comes into place, initial conversations have started how we can continue to take that work forward. And I think the latest, for those of you familiar with the modern service framework that was released nationally a couple of weeks ago, will certainly help drive that impetus, drive that work at local level as well as more system level as well. So in terms of implications and the support from the Health and Wellbeing Board, we continue to ask for the system-wide support for this, based on the evidence that drives the Charter, that it is a system-wide issue and needs contributions from the whole system, and at times the system working very collaboratively together. The targeted interventions to reduce inequalities that are associated with deprivation, ethnicity, age and gender, and ensure that the obesity prevention, physical activity are reflected in all the relevant strategies, but particularly in the work that's been undertaken around poverty. There's a clear link, as I've sort of alluded to repeatedly about deprivation, but there's a clear link between deprivation, stroke poverty, and obesity. And another area is with the focus on employment and health, and we're now very much aware of the impact that obesity has on employment, is another area for development as well, and things like Connect to Work and Get Britain Working is another area that can be taken forward. But coming back to the sort of power of communities and beliefs and culture around obesity, it is something about that place-based approach and working with neighbourhoods and communities from where they are at. And there's just one other thing. I think that we've talked about the environmental impacts on obesity, and many of those are best influenced by national initiatives. There have been a number of consultations that have emerged over the past year, which we've responded to, and we provide the evidence base and actually write the consultation. It would be really good if the Health and Wellbeing Board could submit those consultations under the name of the Health and Wellbeing Board, as I think that would really show that we are thinking as a system around obesity. So I think going back to the recommendations, which now I've way lost them completely because I've whizzed up and down my screen too quickly. I apologise for that. We hope that we provided with enough information for discussion. But thank you very much. But Dami.
Thank you, Val. Just a few reflections from me. Just wanted to share that the data mostly is from 24-25, so it tells us where we have been, but not necessarily where we are now. So, and as Val has rightly said, a lot of work is going on behind the scenes to addressing, some of these issues she's highlighted. And I guess one thing I just want to emphasize in this meeting is for us to look beyond physical activity and diet as the only way to tackling obesity. The science has moved on beyond that. There's a lot of talks about metabolic programming, which is also called developmental programming, and that's where the best start in life interventions is really critical. So there's that critical window where the organ of a child gets programmed, and that determines how the child can be predisposed to obesity or cardiovascular diseases in later life. So whatever we do before conception is really critical. That is, even before the child is born, you're thinking about maternal smoking as well, maternal diet, maternal lifestyle. All those things are critical. And these are some of the conversations we'll continue to have in the obesity charter to ensuring that we have that life course approach to tackling obesity. So that's just what I want to add, that we're doing a lot of work behind the scenes, and as she's rightly said, we'll be coming back again with a paper to share the progress we're making. Thank you.
Thank you, Damilola. Thank you, Val. We move to questions, debate.
Thank you. Just picking up on this point of how you utilize this data, I wonder to what extent you're using it to forecast future demand, either for acute care delivered in hospitals or acute care delivered outside of hospitals. So I ask that on the basis, for example, that we are building a new hospital at Hinchinbrook and trying to build a model of demand for that in its design.
Doctor, yes. Could you get your mic slightly closer?
Sorry, can you hear me now? Yeah.
That's better.
So I'm wondering in terms of how we utilize this to forecast future demand, particularly when we're investing a lot of money in new acute settings and adopting clinical strategies that will allow more acute care to be delivered in out-of-hospital settings.
Do you want, shall we answer the questions as they come, or
yes, please, but I would prefer that.
I think that's a really pertinent point. And I don't, there's work being done nationally, I know, but it's something that we could pick up with because it does add a lot of weight to the arguments for addressing obesity. I think that's a really good point. It's something we could look at, certainly in public health with partners. Thank you.
Thank you. Neil, please.
Thank you, Chair, through you. Having sat on scrutiny for adult health for about the last 7 years, I'm still a bit concerned that we have these reports every year, and for children's and obesity, every year it's worse. Can you just drill down into exactly what we're going to do different that we've done in the last 7 years to actually buck this trend? Because it's okay bringing the reports, but every year we get the same, it's getting worse, and we need to buck this trend somehow. The reports are great, but when it's saying it's going down and down, and we've had that for the last so many years, just want to know what we're going to actually change fundamentally to get this the other way, especially in Peterborough.
Thank you, Neil. I'm going to make a caveat to that and that is something I'm going to comment on, that I think this is way bigger than we can solve through the NHS or the health means. I mean, this problem is complex. Val has made a very good exposition of it in her presentation of the charter. How complex is this? And I wonder whether we have to be very honest and clear about what is it that we can, what proportion of obesity drivers within our remit for influence, really, and what depends on so many other factors and so many other elements. But I left Val probably answer within her scope of expertise.
Okay, so I'll answer your question. What are we going to do differently for Peterborough? So we're not going to be starting from scratch. We're going to be building on what already exists. But if there are 3 things I'm going to say is early intervention. We're going to be doing a lot of work on early intervention. Like I said, the issue around metabolic programming, how do we ensure that even before children are born? Because if you're thinking of interventions at year 6, you're already too late. So how do we ensure that those right interventions are there, before their organs get programmed into, being obese? And then the second thing is about tackling inequalities. In the report, it's clear that people from minority groups, non-English speaking, people in deprived neighborhoods are more likely to be obese. So thinking about what are those drivers? So we're going to be doing a lot of engagement, a lot of community work. We're going to be doing a lot of work on food insecurity as well, because that also contributes. And those are some of the things we're also looking at in the obesity charter. And then the third thing is embedding, obesity is everybody's business. So we're going to continue to ensure that that's embedded in any existing program. So those are the 3 things I can say for now, but when we come back again with the progress, I'll provide more details on what we're doing. Thank you.
But I
Thank you,
think-
Damilola. Yes, Val.
But the key point, whether it's Peterborough or Cambridgeshire, that what we haven't done as well as I think we could do is that system-wide response, that everybody needs to make a contribution, and those areas where there's an interface and the added value through working collaboratively, I think we need to be sharper about identifying those and taking them forward. And that applies, across the piece.
And that is a very good point. I think we have done isolated efforts, some of them that are extremely commendable. I will highlight what Liz Watts has done in South Cambs, a lot of programs that have a lot of merit. I have an awful lot of respect for what she's done there. But if we can bring everything in an integration, we may have a slightly better impact on the outcomes, and this is going to take some time as well. Paul, yes, please.
Thank you. So just reading the report, it feels like there's an absence of information about the role of schools and education in this process, and it may just be a function of the report. In terms of taking a whole system view of this, in terms of the accountability through charters or other mechanisms, how do we measure the agency, the ownership, the activity, physical or focus on free school meals uptake and so on, by each of our schools in their contribution to this, so that we can be clear that we are doing everything we can in that setting with a captive audience for many years, for most of the year, to support this particular programme?
I think that sort of level of detail will certainly bring back to the Charter, because we have doing work around free school meals. And I think it was more, this paper was to pinpoint some of the areas and what needed to be done, but we can bring detail back on this, because what we want to do with the Charter is to pinpoint those points of the system which can really sort of lever in change. So I think it really is a good point. Like, we've done a lot of work with schools, and there's a whole load of programs that go on in schools. I will say, I think it's outside of the free schools issue. I think schools just feel, I think they're very willing, and a lot of them do an awful lot, but they're overwhelmed by a number of pressures.
Please.
And and each school is going to be different in terms of what its data presents, depending on the deprivation, the makeup of its population, and so on. So it certainly shouldn't be used as a stick to beat people. What I think we're interested in is how much focus, energy, and emphasis does the school environment place on sort of the broader development of the child, including a healthy weight. So I think if we could assess and perhaps benchmark some of the commitment to the Charter, uptake of free school meals, all of those key metrics, which would give us a sense of actually how involved and engaged is our education system in this approach. I think that would give us some help. Then we can obviously apply the same lens to all the other partners sat around the table as well. Thank you.
Indeed, John.
Thank you, John. Yes, just reading in your own report, and you mentioned it in your presentation, wow. Obesity more than doubles from the start of primary school to the end of primary school, to year 6. So it seems like we are sending our kids to school to get obese, and if we are not measuring what's happening in the schools, which, as the experience I have got as a parent, but not only that, the experience that I get from, I would say, every parent in my division, is that the school provision is poor. So we don't need to go too far to understand why those things are happening, which is only one factor, okay? There are so many others. The fact that the statistics are getting worse probably is telling us that we have changed habits dramatically, and but that's one of them. So if we can, I don't think it should be so difficult to measure what the quality of food in the schools is, so that's a very important point. I believe I got Liz next, and then Sally, and then Raj, and then Mike. Is that correct? Yeah. Oh, and I got Claire as well. So, Liz.
Thank you, Chair. Thanks, Val, for the report. I found some of the data in the early parts a little bit difficult to understand, as I think the Chair already raised. But I think the main issue I've got for us as a board is that this is really we will see slow progress here. And so just to show us the high level data effectively isn't going to enable us to do anything other than see slow progress. And I think it would be really good to break down, to inform us as a board about what are the kind of shorter term activities that are taking place, and are they working, to give us a sort of a bridge, I suppose, to understand are we making any impact, and if not, do we as a board have a role in influencing those shorter term activities, because that's our only purpose here, right? To try and make change happen where it's not happening. I'm fully supportive of the Obesity Charter, and we are taking it to our cabinet meeting in September to sign up to it. And I think as if we all as organisations take that charter seriously and we take it through our organisations and commit to more system-wide working, I think that might help as well. Thank you.
I think what's emerging from this is you're giving us some very good ideas of what we need to in the next paper, which is more the sort of detail, as this is kind of the overview of where we are against the target.
Thank you, Liz. Thank you, Val. Sally.
Thank you. And I just wanted to recognise all of the work that's happening in this space, but also all the passion and interest in the room on moving this and making a difference, but also recognising it is really complicated. One of the a few points. One of the points I was going to mention on the schools element, just as a sort of aside to that, is the schools is really important, but children and young people do eat about 70% of their food outside of the school. So actually, all of the rest of the environment is really important as well. So it's very complicated, and we need to be tackling everything all at once to try and make a change here. Which is why I think the charter is really important. So the commitment, and Liz, your point around us coming together in this room is about making a difference where we're not able to, and how do we influence and drive that even further forwards. So the bit that I was just thinking about was everybody's committed in this room, and different organisations are taking forward their charter in different ways, hopefully, but that centralised governance of really that visibility of how are we making a difference on those charters, what's the bits that are missing, how do we all come together, but have the detail, because there's so much in this space, have the detailed discussions that need to happen, that we're not going to be able to get to grips with all of it in this room. So the bit around the sort of coalition central to the charter, that's the driving kind of senior leaders in this space, I think we haven't quite established yet, have we, Val and Damilola? So is that the next step on that kind of step down, driving this forward, senior leadership in this space?
I think what we've been doing is that we started with the districts and now moving out to the NHS, view of the fact the NHS was going through changes, and we formed a working group which kind of its membership is growing, and we've sort of got some commitment to that oversight group, because the idea is to have an oversight group of senior leaders from different organisations, which would kind of oversee a working group, would actually drive the pieces of work forward. So it's kind of in progress, and I think we have progressed, but we perhaps could progress a bit faster.
Yeah, Sally.
Yeah, thank you. So I think that's the bit, isn't it, around that oversight group, really being able to hold this and be able to report back in a very comprehensive way on all of these different threads. So I think a commitment to the timeline on that might be helpful.
Thank you, Sally. Right, you wanted to make a comment, yeah?
Yeah, I just wanted to come back on. I just wanted to come back on Councillor Boyce's point about what are we doing specifically in Peterborough, which was really important. I think we saw from that behavioural insights thing that people want to change but face practical, social and environmental barriers to make that change. And I think we have to work, the reason public health came out into local authorities was because of the big impact that local authorities can have. For example, when we are thinking of station quarter or changes to the environment, we have to make sure there are cycle lanes. We have to try and signpost people so that they can walk more and cycle more and make it easier to have active travel. That's one of the big things, that if you can have the ability for active travel, then physical activity gets built in. Similarly, food environment, we have a high salt, sugar advertising policy that says we shouldn't be advertising that. How do we expand that so that it's quite, it's a lot more, I think it has to be the whole council approach to addressing it, and needs member support as well. Thank you.
Thank you, Raj. Mike, you're next.
Thank you, and thank you for the report as ever. I think it's sort of good to see, but disappointing that it's a sort of intractable problem, and it's been around for ages. I remember when I was working for the British Heart Foundation, the Foresight report came out in 2007, which was a fantastic description of the complexity, and yet we're still facing the issues. And as Raj has just said, much of it sits outside health. However, the two questions I had, it would be quite good, I think, to see in these reports what are the consequences of obesity from social, emotional, and physical health. So we can say that gives you quite an incentive to say, you know, we've got to do something about this. So an example in general practice would be diabetes, type 2 diabetes now being seen in children, which previously it wasn't. So that was one thought that might be helpful. And then the other was around inequalities, and to what extent do we move beyond deprivation to mental health being a significant driver of obesity, particularly severe enduring mental health, where many of the treatments are obesogenic, and learning disability. I think that cohort of people are, you know, and Down syndrome and diabetes, the link. And then the last was a very specific thing, which may or may not be relevant, but I wonder to what extent are the new weight loss drugs, Wegovy and Mounjaro, going to impact this. May reduce obesity on the one hand, it may increase inequalities because it's expensive and only rich people can pay for it, rather crudely put. So I don't know whether that's something that we might see having an impact in future. So lots of observations, but hopefully helpful, and I don't know if you want to comment, but no need to do so if you don't want to.
Yeah, I think the outcomes probably...
Your microphone, Val.
So we do normally put in something...
Your microphone.
Oh.
Thank you. It's on? Oh, it's on. All right, sorry.
Is it on? Can you hear me now?
Just there.
Okay, right. I think with the outcomes, we don't normally do put it in, and it comes to a point where you put it in, so you think people sort of... But we could do it as a sort of appendix, just as something, because I agree with you, it's quite compelling. I think the inequities relating to people with mental health and learning disabilities are vast. And certainly we're doing a lot of work around learning disabilities at the moment. And the services that we commission, we have in plan as a development objective for the provider to develop a specific service for people with learning disabilities. So I think I take your point very much about the inequalities around there. Weight loss drugs, yeah, bound to have an impact, I think, but it's very much governed by how future investment will go nationally. It's set to a large degree by national policy. There's some, I leave it to my ICB colleagues to comment more on that. But certainly, I think they're bound to have an impact. And certainly, I was at a meeting recently, I think it was in relation to Hinchinbrook, and the impact that would have there. That was part of the discussion as well. So, but it's a bit of an unknown at the moment because it's changing all the time in terms of the way it's being used.
Yes, thank you. I mean, the other issue, rather than quite apart from inequalities and possibly increasing them, is it creates a cost pressure within the health service, which might divert resources as an opportunity cost in other areas which might need to be considered, I guess. Yeah. Thank you.
It's complex.
Thank you, Mike. Thank you, Val. Yes, Claire, please.
Yeah, thank you. I'm glad you raised GLP-1s, Mike, because I was going to do the same. And it just seems to me, you know, because they now exist in a way that they didn't previously, a kind of fully rounded obesity strategy will need to consider whether we are maximising and targeting usage of them effectively. And I recognise this is a complex, controversial area, but actually the evidence is that they are effective. And as Mike says, we can also see actually there's quite widespread use privately. So it just seems to me to be one of those things that we would want to face really actively into. Just the other bit I wanted to contribute, I thought a really interesting conversation on schools. My understanding is that sports premium funding is being allocated differently from next financial year, and actually one of the consequences of that is that schools are not receiving the funding directly. I know there are conversations in my kids' school about cutting yoga and dance lessons, for example, already as a result of that. So again, these just seem to me, you know, it's a national decision. We're on the receiving end of it, but yet the consequences of it actually could be quite significant for the provision that schools are able to put in place. Thank you.
And I think that thing about national policy and us having a voice when we have the opportunity to have a voice when new things are being proposed is very important. I think having a perspective on GLP-1s they are controversial, but I think the link to inequalities is quite clear in many ways. So to have a view on that would be helpful.
Sally.
Thank you. Just on the GLP-1s, it is rapidly changing national picture in terms of what pathways are going to be commissioned on, what the services are going to look like, whether we have what the options are, what's going to be purchased, and then how that's going to play out locally, and even the modelling of what impact that will have. And I just wondered if there is that written down anywhere for us locally in terms of who's delivering, what's the pathway, what's the future projections. It's a question to Pam probably. Do we have that mapped out clearly? Because it's probably my ignorance, but it feels a bit untangible right now, for me anyway.
Do you know that, Pam?
Yeah, so I think this is part of the new ICB's strategic commissioning function. So with our medicines optimisation team, actually what's the horizon scanning of the benefits that you get to your population through the new medicines, and not just GLP-1s, any medicines that come online. So our strategic evaluation team are looking at this at the moment and mapping that alongside all interventions. But what I would say is that there is a greater opportunity through the lifestyle choices and influences that we're talking about in schools to hardwire physical activity, and that you will never get with a GLP-1 conversation. So it is both and this board needs to be really tuned to the psychological benefit and reduction of isolation that physical activity has. Hardwiring that into children in schools enables us to, put coaching and motivational support in, access, to encourage people to access domestic violence services. When we've had a conversation through a different media, it is very rounded. GLP-1 is part of an obesity approach, and we must do all of those things. But as a strategic commissioner, we're obviously looking, we get the bill for medicines, we're looking at the how we can best get the population supported with those. And there is new guidance coming, there's tablet form coming, there's all sorts of things that have got to be projected through. But I think we can already see that there's a significant reduction in need for surgical interventions, and actually that plays into the availability of other theatre space. There's all sorts of calculations that need to be made on this.
Right, yeah, thank you, Pam.
Yeah, I just wanted to support Pam because this is a health and well-being board. Ideally, we should be looking at before people have become obese and see what we can do to prevent people being obese. And this is actually part of the healthy environment's priority of the health and well-being board. We have to just be focused that we can't solve some of the medical management stuff in this board, because we need to focus on what we can do in terms of our wider organizational reach, that we can actually influence some of these wider determinants which other parts of the system can't do. So I just support Pam that this is actually healthy environment priority, and it's about reducing the obesogenic environment, not about the treatment of obesity, because that can take up all of our time.
Absolutely. Any other comments, Erin?
Thank you. Trying to add to the conversation, I guess, and support a lot of the comments being made already. I think the thing I was kind of going around my head when I read this report was the fact that I'd also just read the King's Fund report this week around some of the neighbourhood models from Brazil and from New Zealand, which are very focused on families and households and the kind of way that we interact. And so I think the where I was kind of landing with that in my head was thinking around how we be really intentionally opportunistic. So there's some stuff we can do that's really intentional and planned. There's also some stuff about being quite intentional about being opportunistic. And I think Mike's point before around medications that we prescribe, particularly antipsychotics and things like that, where we know that people are going to put on weight. There's some really good initiatives around the world where that's embedded with exercise support right from the beginning of your first prescription of antipsychotic. So there's some things like that that I think we could do better at. But the other bit was just, and then the other example I think is that the social supermarkets that are starting to evolve, at least in Cambridge City I know, are really intentionally saying, well, you've come to us for support around food. We're going to have a personalised planning conversation with you in a neighbourhood kind of way. What support can we put around you as a person and a family and a household that means in 12 weeks' time you won't need our support from a social supermarket perspective? But I know they're also keen to look at that from an inequalities perspective. So I think there's a few things like that that we could start to explore through the neighbourhood work that might be some of those, who said it before, Liz, some of those shorter term things that we can get in place that will be quite hard to evaluate, but hopefully really useful and pick up on the fact that those children we're really worried about live in those households where the parents are more likely to be struggling to navigate life and juggle life and the things they've got going on for themselves. So getting in and out of work, that kind of stuff. So I think there's something about how we keep building that neighbourhood bit that we're doing for kind of frailty and things, but how we do some of these smaller things on the side to just start moving this in a really positive direction.
Thank you, Erin.
Thank you. Just on a similar theme, I wonder if we shouldn't be making more of the opportunities to utilise some of the new digital applications that we're seeing now in health and wellness apps. And increasingly, these allow very much a personalised approach. So if adults are using these new health and wellness apps, they can be given predictions of the likelihood of ill health developing. So they take account of personal circumstances as well as social and health backgrounds to, as I say, give an early warning to individuals about what conditions may develop should they not change their lifestyles. Because what tends to happen, I think, is that people will access health services at the point they feel unwell or know something is wrong. And at that point, just in economic terms, it's far more expensive set of conditions that you have to deal with. The one benefit, I think, of the health and wellness apps is that they tend to be free, whereas the the weight loss drugs, as you're indicating, are certainly not free.
Thank you. Any other comments? Thank you very much, everyone, for all the input. Incredibly complex problem. What I want to say as well on this is, yes, it is very disappointing, as one person mentioned, the report. And let me tell you something, I think it's going to be even more disappointing, not only next year, but the year following, And I know, Neil, you're concerned. We're politicians. We want to have and present better things, better outcomes. It's not going to happen soon. But I'm incredibly grateful to the public health teams for the obesity charter. It is the right framework to work with. At some point, we're going to map out all these ideas and many others that are out there. This represents an incredible challenge, and what an opportunity for us to make an impact. We are not the economic policy makers. We don't decide on housing. We don't decide on transport, at least not directly. But in our remit, we can make a real contribution to this, and we are going to make it. There is so much energy, so much knowledge. I already mentioned Liz. I know that Pam has done terrific work in her previous job, and I know the commitment of many of you here and your experience and your enthusiasm. We are going to make an impact. Make no doubt about it. No matter how the figures look now, this is not a race. We're going to make an impact in the long run. Okay. So thank you, everybody, so much.
Thank you.
Let me read the decision. The Cambridgeshire Peterborough Health and Wellbeing Board Integrated Care Partnership is being asked to review the progress against the target ambitions for obesity and physical activity and support the following high-level commitments connected to the further detail given in the report. So they are to commit to actively supporting the identified areas for strategic and operational change and the associated action points, to commit to addressing the drivers of inequalities and inequities of childhood and adult obesity and low levels of physical activity, and to submit responses to any national consultations on behalf of the system if there is positive evidence for the change. Are we content to agree to these recommendations? Excellent. Okay, we take that as agreed.
Thank you. Confirmed as agreed.
Thank you, Casey. Item 5 is the update on expansion on the Health and Wellbeing Board Priority 2 to include the wider determinants of health. This item can be found in pages 161 to 172 of the agenda. Sarah Duggan, Consultant in Public Health, please, will you now introduce it?
Is that, yeah. Hello, I'm Sarah Dugan. I'm one of the consultants in public health at Cambridgeshire County Council. And I have co-authored this paper alongside one of the place directors, Adrian Chapman, who unfortunately isn't here today, but Ian is deputising for him. Also, Andrea Woods from the Combined Authority, and Tim will chip in on her behalf as well, and then also with Pam from an ICB perspective. So the proposal is that we expand Priority 2 of the Joint Health and Wellbeing Board strategy to cover more of the wider determinants of health. At the moment, as you've heard just from Val, the priority is more specifically about obesity. The reason we're coming today to recommend expanding it is there's a lot of growing opportunities within the area of the wider determinants of health, and we think we should be capitalising on them as a system. So the wider determinants of health do include things like transport planning, housing, employment, and all those things that, and the environment that people have been talking about through the obesity charter as well. The three main opportunities associated with it is we have quite strong system-wide governance on place. So that is all the local authority directors come together in this governance called Place Directors. Judith Barker at the Combined Authority chairs it, and there are representatives from all of from Peterborough City Council, Cambridgeshire County Council, and all the district councils. They are the executive directors and directors who oversee environment, waste, planning, and housing. So there's quite a good opportunity there for us to bring in some of the health work, and they are supportive of that. I'll talk through that a bit more in a moment. There's also a new mayoral health duty that has come in through the devolution bill. So strategic authorities like Cambridge and Peterborough Combined Authority need to start having a regard to or a duty on health inequalities. There is also some funding attached to that through the Health Foundation, which we can bid for. Again, if we're more organised and coordinated on some of this, we'd have greater opportunities to get that funding. And then lastly, there's growing, the public health academics are really keen to start working with the system more. We have had quite a lot of, we've had a couple of workshops with them on the opportunities between public health and their academic work. Alongside their growing enthusiasm to work with us, and they would want to work with us on a big footprint and in a structured way. There are more and more public health research grants coming through the National Institutes of Health Research, which are focused on the wider determinants of health. And again, if we can coordinate and coalesce the system in looking at what research questions we want to answer on a big scale, I think we'd have more of a chance of successfully getting some of that funding, obviously working with our academic partners. So we're asking the board to support to take this forward. I guess the biggest thing we would move on at the moment, because the combined authority need to work out what they do with the mayoral health duty. They've only just received it, and I don't think there's full clarity on what is required. But our biggest opportunity at the moment is around the place directors. The place directors are have just reviewed the themes of their work. They have 7 themes. So we are proposing that one of those 7 is healthy place. We already do a lot of work across some of the place directors' work in work and health, in housing and health, and in planning. We're not suggesting we stop that. We're saying that we continue within all their other themes to do work through public health and through the ICB and other partners, but just then we would have this separate group that has a very specific focus on healthy place and brings some of that together. On the group, then, we would invite some of those senior academics who are keen to work with us to sit on it too, and that's how they can hook into the system. We would also bring in all the public health evidence and intelligence. We're also recommending that the group in the first instance focuses on planning and specifically the spatial development strategy, which Cambridgeshire and Peterborough will need to do. This is a strategy around what will happen. It's a vision for what happens in terms of spatial development in the next few decades. We want to ensure, like other areas such as Liverpool have done, that health is very strongly embedded in that. And we would do that then through this Healthy Places group at the health directors. The other area of work, which I know, and I've been working with some of your teams on, is on transport. We've specifically been doing some work on community transport, where there are lots of issues for very vulnerable residents and also interfacing into the NHS, as well as what's happening through some of the combined authority programmes. And then there are wider issues on transport as well, which I think will come up and which we could usefully look at through that group. All of this does link in with the integrated neighbourhoods work as well, and we will work to do that. So some of the transport work links back down to integrated neighbourhoods. Some of the planning work obviously will feed into that as well, and some of the work on NHS estates. So that was it, Chair. It was just to ask the board to support this expansion and the setting up of the place directors theme. Thank you.
Thank you very much, Sarah. So I spoke too soon. We actually do to make all those decisions in economy and housing and everything. At least we influence now. I know what you mean, but it's great. It's great to see. Yes, please.
Yeah, thanks, Chairman. So it's a really well-written report. Really committed to this in principle. I think it's an excellent opportunity to help local authorities engage in a practical way with the kind of wider health agenda. So I agree that these wider determinants of health being better connected is something we've been grappling with for some considerable time. So I think this is a step in the right direction. I think, as ever, it's how this commitment translates into practical interventions that are going to make a difference. And to that end, it's pleased to note there is the commitment to go away and work up an action plan that will do that, will identify practical interventions to connect with this priority. So obviously it stands to reason it'll be good to see that, to engage with that, to understand that, to challenge that at the point in time that's been worked up. But yeah, in principle, I think this is really positive. Thank you.
Thank you very much. Okay, I have John, then Neil, then Dorothy, then Sally, and then I go around the table here. Great. John.
Thank you. How does one access the £1.3 million? And to Paul's point, make it directly allocated to voluntary sector organisations or local partners actually delivering on finding and supporting people who may be having inequitable outcomes. I think one of the challenges we should say is how do we get that to practical interventions pretty quickly, and how do we as a Health and Wellbeing Board have some oversight of that so we're clear we're not spending, and I'm not suggesting anyone's planning on doing this, but spend a load on programme costs and planning rather than have we found some people and supported them in their local neighbourhood. So yeah, my plea is, can we be involved, and can we help find the right solutions, and then can we oversee it here, please?
So if I can come back on that. So I think the 1.3 million will be available to CPCA. So we would have to ask them to agree that, John. I don't think we will get all of the 1.3 million. It is for across all the strategic authorities. But I don't know, Tim, if you wanted to add more on that.
Thank you. Yes, so we would be able to apply for some of the funding from the Health Foundation, and we would commit to work in partnership with our place-based partners and public health and the whole system to actually deliver it and deliver on the objectives of that funding. But it is specific and will be directed by the Health Foundation as to its purpose and its use, and that remains unclear at the moment. The Governance Board earlier this week for the Mayoral Regions Programme were unable to ascertain exactly which areas that funding would cover, and further clarification will be brought later down the line.
Okay, thank you. Neil?
Thank you, Chair. Firstly, I really welcome this report. Part of the report mentions planners and planning local plans, which is a long time overdue, having health into local plans. But with planners, when it comes to developers, health doesn't normally mean to them profit. Are we getting a buy-in from developers when it comes to looking at health? And if not, what can we do to actually assist that and actually make it the norm rather than something else?
For large developments, developers would normally have to put in a health impact assessment. So there is quite a lot of work in the system, and we're ahead of other systems in having dedicated health officers who do assess what comes in. I think I share some of your concerns, because I then think as it goes through the process, maybe things are dropped. There is potentially a bit of work we can do on that, about whether what goes in at the beginning then does get seen in the final development. But I think we're in a better place than most areas in terms of this. And as I said, there is a lot of work that goes into checking those health impact assessments are where they should be. Our planners are also really keen and do already work with public health, and there is a health officer in South Cambs as well. So we've got lots of engagement. It's just, I think it is what happens in the final delivery sometimes of those developments. But yes, we could do more work on that and look at that.
Thank you. I'm going to go Dorothy, please.
Thank you very much. We're very much welcome this work. I just want to pick up on the point that Paul made about consent of making to action. But what I would hope is it actually finds evidence in the policies which you're reviewing. So we're going to look at the separate action plan, but we have a mechanism to hold to account things which are identified through their impact assessments. So it's that balance between this being separate, but creating a mechanism to hold to account as you actually look at the policies. I think that what we'll have in obesity is that some of the levers that we could be using, we aren't using as effectively we could. And it's that mechanism to hold to account. And what would the role of this committee be? Thank you.
So I agree, Dorothy, and we will look at where we can build on work that's already ongoing rather than setting up a whole load of new work. I think in terms of how this committee holds things to account, we can bring regular updates here. And I guess if we get stuck on a specific issue, maybe we could come back and get your support with that, or you could help us navigate it. But thank you.
Sally, please.
Thank you. So I also really welcome this report. I think it's really important. And I think recognising the conversation that we had previously on obesity, there is a real recognition in this room and support of those social determinants and the wider environmental factors that we, as a Health and Wellbeing Board coming together on, we can get more clout behind. And I just also wanted to recognise that across the Central East ICB footprint, we are unique in Cambridgeshire and Peterborough that we do have the combined authority. And I think the opportunity for us to really bring in the conversation around the combined authority into the Health and Wellbeing Board space and around the social determinants in the built environment is really, really key for us. So I think I just really welcome the opportunity, and I wholly endorse the health and place direct, sorry, I got the name wrong, whatever we were saying it's called. I wholly endorse the proposal to move this forward in this way. So yeah, I just wanted to recognise that support.
Thank you, Sally. Do you have your hand up? Mike. Then it was Mike, yeah.
Yeah, so like others, strongly support this. And what I was wondering, when we talk about health and well-being, it's obviously the wider determinants of health, which have been well presented and discussed. But then there is a question, so what is the NHS doing in this space? And I just wanted to say that certainly at Cambridge and Peterborough Foundation Trust, we are pursuing and hoping to sign up to become a Marmot Trust, which is an NHS trust signing up to the Marmot principles, which are all about the wider determinants of health. And it was just a thought whether other NHS trusts are thinking of doing that. It aligns, I think, with the anchor institution notions, but I think, if we as a county and Peterborough, Cambridge, if we were all signed up to that, I think that then provides a bridge between NHS and the work you're doing in terms of public health and the wider determinants. So it was just a thought which I'd sort of put on the table.
Thank you very much, Mike. Graham.
Thank you, Chair. I have a couple of questions. I think this is an excellent idea, Sarah, and I'm very happy to support it. The first question is, how does it overlap with the mayoral health duty? Are we going to be informed about what the mayor is doing? Are we going to have an ability to influence what the mayor is doing, and how is that going to work? And secondly, I'm currently chair of the County Council's Adults Committee and I just wonder whether or not you're expecting me or Lewis to respond on behalf of other place and transport and other responsibilities of the County Council or not, or whether or not we need other people here for these sort of discussions.
Thank you, Graham.
Thanks, Councillor Wilson. I think, Tim, I would like to be in a place where we can influence what the mayor does in the statutory duty of the combined authority. But I think, Tim, I'll hand that one to you. Thanks.
I will probably give a very standard statement to this. At the moment, we are currently reviewing the mayoral health duty and the implication and the requirements. An update will be provided later, but I would commit that we are going to be working with our system partners to develop the strategy rather than create a new framework, but to integrate and develop and build on the existing framework and work very closely in partnership with people.
Okay.
And just on getting different people's feedback on it, I think once we work up the action plan and what the specific topics are, we probably need to look at which routes things go up through the governance, and it might be that they have to go up multiple routes. And I would be really keen that we start getting health on the agenda of other committees, obviously associated with their policies and strategies. But I think that would be easier to answer when I have the specifics of what we will do. And that's the same for in the NHS as well, because there's quite a lot on transport and where there are challenges with transport and what happens in the NHS. And some of that needs to go up through some of the NHS groups and boards and committees. So, yeah, if it's okay, I'll look at that when we have the specifics. But...
Thank you. I'll go, Erin, and I'll finish with you, Pam, around the table. Is that all right? Erin.
Thank you. I just wanted to reflect on the point earlier around planning processes, and just to recognise that from a South Place perspective, we've been working quite hard with the Greater Cambridge planning team around how we feed into the new local plan from a health perspective that stretches beyond general practice and primary care as well, which has typically been the way that input has gone into that chapter. And then stretching that further into thinking about what that means for neighbourhood health centres going forward. And I think that's a really obvious place where some of this, all of this comes together, this conversation we're just having. I think the other bit that I had in my mind was new hospitals, also big developments. And I was particularly thinking about cancer and children's from our perspective, but Hinchinbrook, I guess, is the same in terms of how we work with those developers and their kind of, they're massive organisations. How do we kind of capitalise on that? And we've started very, very early conversations around the mental health and construction workers and the issues around that. And is there some things we can do when we're thinking about building the new hospitals with the kind of, I don't know how many construction workers that is, but I'm guessing like tens of thousands of people over the course of building them, in terms of then influencing back into their households, and just thinking about how we take, again, coming back to that kind of intentionally opportunistic point, how do we make the most of some of the things that we've got a little bit more control over, and how we use them in their anchor role, even as they're being built, to really improve the health and those wider determinants, and kind of feed that back into our communities.
Yeah. And Cambridge Children's Hospital might be a good example for that. I'll go Pam, and then I'll go Sally, and then I'll go you.
Sarah, obviously, I very much welcome the report and thank you for channeling the causes of the causes through there, which where I did my previous work about 10 years ago, and we were a marmot place. That was what changed the dial completely. Things have moved on, and we need to challenge ourselves as to whether, we're not going to get into the debate today, as to whether Marmot's theory is fit for the landscape we're in now. But generating a social movement where the causes of ill health are understood by everybody in the room, and it rolls into everyone's papers and policies. And for the councillor on the end, I'm sorry I've missed his surname, but I spend an inordinate amount of time feeding into planning because it is absolutely critical. And like Erin, I'm very willing to spend any time with planning teams around how we build healthy environments. Just by going and saying, can we create something like edible Ebbsfleet in our planning, where we're relentless around community allotments, and the legacy around skills and growing healthy food would be something we would want to kind of support in new communities, as well as absolutely rigorous views of a active travel society, and that being equitable. Because actually, when you start to slice and dice these things through inequalities, they're not equitable. Travel is one of the most inequitable things, and changes access and reinforces the inequality. So I'm hugely supportive of this but we need to connect everybody's theories into this and everybody's work and practice into this. From a strategic commissioner perspective, we are, and Sally will support as with Raj, we're getting more forensic with our population health data. So no discussion on any population health will be absent of inequality and external determinants. So I guess the challenge is place directors broad enough as a community, and how do we all here channel this type of theory into the work that we're doing? And I think, Sarah, perhaps us bringing something back around the delivery with place, around how we truly anchor that into the decisions that are made and the strategies that come forward, is really important.
Thanks, Pam. Sally, you have a comment on that?
Yeah, thank you. That's really chimes with what was going through my head as well, actually, because I was going to come back in on the Marmot health equity point that Mike made, because I've been thinking about this a lot since I came into post here. Where I was previously, we were a Marmot town, and I've spoken to the chief exec of CPFT about it as well, around the idea about being a Marmot trust and whether we could collaborate on something. But there's been so much change in the system. It sort of, I've been thinking more around, similar to what Pam was saying, how do we embed those principles anyway through everything we're doing? But actually we could still look at that. So I think there's a few options on the table around some of that, but option one is definitely, in any case, we need to be embedding the principles across all that we're doing, and how do we do that in the best way? And the purpose and vision and values piece that we did as part of the Neighbourhood Delivery Committee, and that we brought to the development session here, is trying to start to do that incorporation of those core values across everything we're doing, being in the papers, this work. But I just wonder if there's something more explicit that we could be looking at as part of that, and whether there's a piece to sort of go away and do a bit of thinking around what's the range of options on really embedding that even further, and are we going far enough? And if we think the answer to that is no, I don't think we are, what are the other options that we could have, thinking about the role of the combined authority and the uniqueness of that and our footprint, and how it kind of can all come together. So I do think there's a little bit more thinking that we could take away on some of that as part of this work, as kind of the step two, as the health duty gets clearer as well.
Yep. Thank you, Sally. Yes, please, Doctor.
Thank you. Just to respond to Erin's important point, I think there is some work going on to maximise the investment that's going to go into the local economies from the new hospital. So probably close to £2 billion worth of investment is going to go into those local economies. And we need to ensure that we are targeting not just the provision of healthcare, but utilising those investments for supporting these determinants of health, whether that's jobs, housing, transport, and so on. And in the case of Hinchinbrook Hospital, we have signed an MOU with Huntingdonshire District Council, which is going to help the two organisations to work together with partners to do just that, maximising of the investment in the local economy. What we've also done with our colleagues at CUH is to align our clinical strategies more effectively, so that we can focus on delivering only those services in those new hospitals that need hospital provision, but at the same time working on those services which can be safely and more appropriately provided out of hospital settings. But the important point, I think, is where we have significant investment going into those local economies, it's not just for the provision of services in buildings, it's to strengthen those local economies in as broad a way as we can.
Thank you very much. Any other comments from the room? I make one. I don't know where exactly in the agenda I wanted to mention it, but I want to mention it just for the record as well, and because you're focusing on two particular items of the 7, and planning is the first, whether we are taking into consideration what is clear now, the impact of climate change in our lives, and whether we are going to have that in mind, not only in the way we plan our services and everything we do, but also how we budget, because this is going to be costly, I have the feeling. So I mentioned that at SRP committee. I am sure that Neil might have already mentioned that in adults' health, which is going to be a massive impact for social care. But yes, I may just as well mention that here. So thank you very much, Sarah. I don't know whether that is already something that is being discussed to an extent.
So it is to an extent, but I'm sure we can go further. And as people will be aware, so it is going into local plans about what adaptations should be made for climate change and what developers should be considering and things. But as people will be aware, water or shortage of water is the region's biggest issue with respect to planning and the spatial development strategy. So I'm sure there's more we could be doing, so we can pick that up. Thank you.
Thank you very much. Right, so the Cambridgeshire and Peterborough Health and Wellbeing Board Integrated Care Partnership is asked to recognize the need and the current opportunities for increased focus on and action on the wider determinants of health related to the new mayoral duty on health inequalities, the well-established governance and work of Cambridgeshire and Peterborough's local authority place directors, and growing links with public health academics. Support the proposed health priority for the place directors with a focus on planning and transport, and to ensure that all health and wellbeing board partners are cited and involved in the work in the appropriate way. All in favor? Fantastic. Thank you. We know that.
Thank you very much. For confirmation of the minutes, everybody's in agreement. Thank you.
Thank you very much. Thank you, Sarah. Thank you, Neil. Item 6 is the Cambridgeshire Annual Director of Public Health Report 2026, Creating the Conditions to Thrive, Children and Young People's Mental Health and Wellbeing. This item can be found on pages 173 to 242 of the agenda. Sally Cartwright, Director of Public Health for Cambridgeshire County Council, will introduce the report. Thank you.
Thank you. I'm just going to give a brief introduction and then hand over to my colleague Richard, who's done a lot of the heavy lifting in the background on this paper. So whilst it's the Director of Public Health report, whole credit to Richard for doing the majority of the thinking on it and writing. So yes, huge credit to Richard for the report. But for those that aren't aware, the Director of Public Health has a statutory duty to produce an independent report on essentially on a topic of their choosing that's relevant to the population, to shine a light on a particular issue, to galvanise action on a particular issue. And so this year we chose to do a report on children and young people's mental health and wellbeing, as it is an increasingly prominent topic nationally, but also locally. It's highlighted in various reports that have been written. We had the Children and Young People's Mental Health Needs Assessment, but we've also had a Quality of Life survey. We have a Healthy Behaviours survey in schools, and everything is pointing to this being a growing and dominant issue that we need to tackle, but it's also really challenging and complex and difficult to really understand what actually would make a difference or what should we all be doing. So the purpose of the report is really to triangulate and synthesize all the plethora of data that we have and just think about getting it into a digestible space that can trigger further activity that will make a difference is the intention, but that is quite a challenge. So I will hand over to Richard to talk to the report, and then we'll open up to any questions.
Welcome, Richard, please.
Thank you very much, and good afternoon. I'd just like to acknowledge that the report has been a team effort, and to particularly thank colleagues in the public health team, comms, other parts of the council, and local partners in the system who've contributed. So building on what Sally's said in her introduction, the motivation behind this year's report was to address this timely topic and keep it firmly on the local agenda as a priority, but to do so in a way which takes more of a public health approach. So, as noted, we've tried to triangulate key sources of local data and evidence in a digestible form, bring in the voice of local children and young people of all ages, shift the narrative away from NHS mental health services as being the only solution, and reframe it towards wider determinants and prevention with a focus on poverty as a root cause of inequalities. We've also sought to showcase the great work of local services and partners in terms of prevention and early intervention, and to really take stock of the existing local strategies and recommendations and what they're telling us within the wider national context, which itself is evolving quite rapidly. So as you can see, we have made some recommendations on key topics in the report to try to ensure that we maximise the opportunities from the current major change programmes going on in the NHS, in local government, including neighbourhood health, Best Start in Life, and education and send reforms. So today we're asking the board to approve the publication of the report and to endorse these recommendations. And now we would welcome any feedback on the report and any discussion on the opportunities to collaborate better as a system on this priority during this time of significant change and change programmes.
Thank you very much, Richard. Comments on this presentation, please. Yes.
Thank you, Chair. Firstly, let me say that I thought the report was very well written, and I would like to say on behalf of Andrea that I'm sure she would like to collaborate in future with you around her young person strategy, which is currently under development, and around the work that the Youth Guarantee is doing to deliver support to mental health in terms of collaborating that integration and how we work together. And I also think that I will take a commitment, I can say on my behalf of the work that I do for WorkWell and the ICB, to help with the integration of the sort of WorkWell programs and Connect to Work, which supports obviously those over 16 and over 18 respectively. But I think it's a great opportunity and a very worthwhile cause.
Thank you very much. Mike?
Yes, hello, I'm Mike Napton. I work at Cambridge and Peterborough Foundation Trust. I'm one of the non-exec directors. And so I welcome the report as well. And I absolutely take the point, given that I come from a mental health provider, that this is about not necessarily provision of NHS services to deal with this issue, which is important, but not the primary focus here. So that's the first thing. So the two questions, though, well, 3 points, really. One was you draw out poverty as one of the drivers here, as a sort of inequality, and I just wondered whether there were other areas of inequality that might be useful to think about, such as race, Roma communities, geographical stuff, as well as socioeconomic factors or not, and whether that comes through strongly enough. The second was, I can't not say that mental health, Dame Rachel D'Souza's report that recently came out referred to the fact that 1 million children are being referred to mental health services. So that is a big number, and therefore then I'm trying to make the link between the broader determinants of health and the NHS, and a link I think is important to make in terms of what is the contribution. We've got lots of children on our waiting list for neurodevelopmental delay assessments, for instance. And then the last is it's a bit like the obesity thing. It's a big problem. We talk about it all the time, and it's kind of resistant. It's difficult to move the dial and deal with these issues. And I just wondered if there was any possibility of expanding on recommendation 1, which is, where is the governance and leadership for this work? So you talk about right leadership, partnership structures. So the obvious next question is, so what are they and who are they? So those were the 3 points I wanted to make.
Thanks, Mike. Richard, Sally?
Thanks very much for both your comments, and thank you, Mike. Yes, particularly on the first point, there was a choice to focus on poverty, and it is not meant to be at the exclusion of other forms of inequality, which are very much important. And I would highlight the extensive coverage in the mental health needs assessment, which was jointly led by consultants of public health between your trust and between the councils over a number of years. And in that, that is a much more comprehensive coverage of a lot of these topics, which we didn't seek to recreate here. And I would even note that Catherine Faulkner, who's the consultant in your trust, who kindly gave feedback on this report, did identify that, and particularly in the context of race and racism, as one of the things which should come through more strongly. So I definitely agree with that. And there was a degree of choosing to focus on poverty here, recognising that we weren't seeking to recreate the comprehensive work of the mental health needs assessment. In terms of the other questions, again, while we're seeking to sort of reframe some of the discourse here, we are not trying to ignore or anything else those who, the children and young people who are on waiting lists, who may be struggling to access support that they need. And hopefully it is reflected in here that there is other work ongoing locally which is focused on the provision of services, including NHS services and access to those services. And I think hopefully by broadening the discourse a bit, there is something about recognising that wider responsibility, that the solution does not just sit with expanding the provision of mental health services, and that in many respects, if we get things right earlier, and if we meet people's needs earlier in a universal context, we can prevent some of that need reaching that sort of level of threshold or severity. And again, I would say that we have a lot of strengths locally in partnership working with our voluntary sector colleagues and with NHS colleagues who work specifically in schools, so highlighting the work of the mental health support teams, which is a programme which is being rolled out to achieve full coverage of all schools locally and nationally, and that I think we're about 65% coverage of our local schools, with a plan for full coverage by 2030. And so I guess the point I'm making is, by broadening out how we think about this, we also need to broaden out which services are the right ways to help people at the right point, and making sure that that happens early and not at a late stage where requirement tips over into needing that higher level of support from secondary mental health services. And to your third point, in many respects, that recommendation is a bit of a prompt and a challenge to everyone here today to recognise that we don't have the right vehicle currently to drive this from a governance perspective locally. And part of the challenge is sort of marrying up the commitment that we have seen previously here at the board to this topic with all that's going on across all of these different change programmes, but also the need to think ever more at place level locally. And so again, particularly in the context of the changes with our local ICB in recent times, there is that key challenge to us to now build those structures and partnerships to take this forward.
Many thanks indeed, and I take the challenge on board. We'll, I think, have to think about that. Yeah.
Thank you. I think it's Graham, and then John, and then Dorothy.
Thank you, Chair. I think, Sally, in your introduction, you said that you can choose the topic. So can we influence you as to what topic you might choose next year? And can I suggest that we include obesity in some form or other in your decision making? And because the recommendations that are included here are absolutely excellent, and I fully support everything that Richard and colleagues have written. I'm just thinking ahead for next year.
Yes, it's a good point. I have a list of considerations. I was just looking at it yesterday, actually, and obesity is on there. But so you can influence. I get to decide. But yeah, yes, I think it's I think and Raj obviously has a DPH report as well. And the criteria in my head is something, it needs to add something new or shine extra light on something that is not getting the traction that it needs to, rather than sort of rehashing. So there needs to be something new and different that we're trying to say in it, and that it will trigger some action is in my head. So obesity is absolutely an important issue, whether we already have all the information and actions that we need is a question, or whether there's something in addition a DPH report would add to it. So I have some thinking to do on it. Thank you.
Thank you. John?
Thank you very much for the report, Richard. Could I just ask a question about the considerations? And within there's not one specifically around technology. So as part of often stated problem, whether we like it or not, is the solution too. And our consideration of the technology-led solutions that we want to put in place to support capturing, understanding and improving people's mental health through their own actions. So that's my first question. Second question, Chair, if I may. We talk about within this around some of the reviews of services. So last year, the ICB and CPFT co-sponsored a review of mental health and community services. And I'd just be interested to know to what extent that has shown the delta between demand and supply of services and the gaps we've got, and to what extent we can quantify that. Which then comes on to my final point. We talk in here about a neighbourhood health solution. It's difficult to understand how we would build a service led by carbon-based life forms, which don't currently exist, to support the needs of individuals in a neighbourhood who may be at some risk and may not currently be served by existing services. What size, scale, scope, criteria we would want to establish in neighbourhoods to support the ongoing support and treatment of those individuals. So there's something about the right sizing, but if we are going to build the capability in a neighbourhood environment, we've got to recognise that and many of those services don't exist currently. And quite frankly, while we often use neighbourhoods as a solution for everything, without that investment and deliberate building of infrastructure and capability and people within them, we won't be able to close the delta that you've identified in the report. Thank you.
Thank you, John. That's
some big questions there, some of which I will struggle to give a coherent answer to. In terms of technology-led solutions, I would certainly welcome a conversation in terms of what you see in that sphere. I suppose the one thing I would note is that in terms of some of the local options offered that are covered in the report, there is, for example, Couth, which is a web-based sort of way to seek support. But certainly in terms of some of those other points you make about sort of better capturing and understanding sort of need and levels in the population, again, that's an area I would welcome conversation about how we can do that better. In terms of the Community Mental Health Services review that you referred to last year, I think in terms of what I've seen of the output from that, it was high-level recommendations. And alongside that, I think we were hoping to see more in terms of the concrete delta that you describe. And being able to quantify sort of the financial input into services, what the makeup of services is from a kind of activity and workforce point of view, and what data we could produce on an outcome basis. And I think we're hoping to see, and again, that's a very challenging equation, and to do that across all the services, again, very challenging. I would just highlight, again, it's mentioned in the report, but alongside that, we were separately doing a piece focused just on children and young people with commissioners from the ICB, which included a rapid review of existing evidence locally and included structured stakeholder engagement in terms of trying to identify opportunities, particularly from a perspective of how we commission services going forward. So the hope was those two would complement each other. And again, I think we are still looking to take both forward in the space of children and young people, again, recognising that the ICB is sort of nearly at the point of being fully restructured and staffed at this point going forwards. In terms of your last question, again, I think there's a wider conversation to be had going forwards. And I think I would see it less that we're trying to build something new, but perhaps more that we're trying to better integrate and coordinate what is already happening at the local level across, for example, primary care, education, voluntary sector, to make sure that we, again, that local partners are able to connect people to the right service at the right time, but also to communicate with each other in terms of how best to manage people with specific presenting needs, and especially where there is specific risks to be held. So again, I know that's not necessarily a strong answer to your question or your challenge, but I hope this can be, an ongoing conversation how we best do.
Thank you, Richard. Do you want to make John?
Yes, please. Yeah. I mean, I think for the review of children's mental health services, it'd be good to release that data from CPFT, ICB colleagues to know where we are. And it's absolutely right in this report. It's not saying where we want to be, but where we are and what issues we've got to resolve. When we've looked particularly at creating multidisciplinary teams around children and young people, particularly with mental health concerns, behavioural concerns, what we quickly run up against is the levels of risk held. So it's quite difficult to marshal people around and go, come on, we can all collectively hold this risk, because life doesn't work like that, and it shouldn't work like that, because the solution needs to be watertight. So when we are looking to say we need a neighbourhood health response, we need to be very clear. Who's the accountable organisation? Who are they partnering with through formal arrangements, and how are we managing that risk? And that's not necessarily to replace existing services, which often got quite a high bar to access currently because of their capacity, but how do you manage some of that unknown risk that may present itself in your neighbourhood with children and young people every day, and who's going to be responsible for that? So I think that's the careful consideration around these services that we need to construct, and recognising that our starting point is a completely inadequate level of supply. And I think part of the solution I think we should explore, like most of our services now, is what's the technology that enables us to have the greatest reach and the greatest ability to manage risk most effectively. So very happy to work with you on that.
Thank you, John. Pam, if you can hold it just a second, I'm going to go Dorothy first, and then you, and then Raj. Excellent. We finish with Raj. Dorothy, it's your turn. Can you hear me there, Dorothy?
Thank you very much. Can I start by congratulating the UK on good topics? I mean, both Raj reporting exercise and your report on children's mental health. I also welcome the approach of having positive recommendations. It has John Peterson been really risky topic, but what you brought out are things like play, the support for positive parenting, the best starting life. There's lots of things that we raise positively, we create that environment. And it's just making sure that as we look forward to see that positive approach to these efforts, as well as understanding around the risks. And then there's another aspect for me, which is these recommendations do make sense, but they can make sense if they can align. And so there's that sense of bringing them back in 6 months' time, see where we are and what we can then help our being forward to bring things alive. It's hard to help you, not just what you're supposed to learn in this time. So thank you.
Thank you very much, Dorothy. Pam, you want to add to that?
Yeah, just to augment what Dorothy said, I think if you know, we've had this discussion, haven't we, before about the state of flux of the ICB and who you were working with before maybe isn't there now. But what we need to do is ensure that you're comfortable with the care model that is in our way document, which is our 5-year strategy, which I've given to Ian this morning so that it can be circulated. And I'll happily talk to anyone about that approach. But children and young people are absolutely a strategic priority across the ICB, particularly focusing on neurodiversity and the pathways, they're symptom-based pathways as opposed to diagnostic pathways, so that we can have a more rounded conversation rather than a medicalised conversation. And that is the principle that we're applying to children and young people. We know from the work actually that if you can start to do therapeutic involvement earlier, actually you start to reduce the need for higher intervention later in life. So this does roll. I think the delta that John's spoken about is a we've got to take a philosophical look at whether delta in the new world is the same as it is now. Because actually, if we're able to mobilise the resources into stronger communities, going back to everything that we've talked about today, will have an impact on the caseload for children and young people. And we need to preserve then the high intensity resource, so looking at crisis resources to be able to be responsive enough. And there is design across that within the care model as well. So it's a priority. We've established a local children's and young people's board subcommittee of the Neighbourhood Health Committee. We started doing some work in our development session last week around that. This will replace, refocus what were accountable business units before, which in honesty, I hadn't seen the visibility of that work when I arrived here. So we've taken a look at that and said something needs to change. We've got the benefit of Central East on this. Okay, so there is good practice across 3.5 million population. And it has been reviewed and it has been tested. And it doesn't mean that it couldn't be delivered here and be delivered here rapidly and effectively. So I think there's a broader scope now around the evidence base and the commissioning and purchasing that we're doing already, and that will link directly into the community services and mental health review as well, because I think there is good practice across Central East that we want to share for the people of Cambridge and Peterborough. Sometimes it helps to be able to look out.
Thank you, Pam. Well, that's encouraging. Raj.
Thank you, Richard and Sally. That's a great report and really good. It's very helpful. So I can just change the data and say this is the Peterborough annual report with a tweak to some of the data. Besides that, the broader point I wanted to make was we've got these two twin epidemics, obesity and mental health. And in terms of Graham's challenge, I think, would you see them as sort of having similar determinants? Because, well, I'm not a psychiatrist, but when I talked to a psychiatrist, he said the first thing I have to do when people come with mental health issues is tell them to sort out their physical activity and diet and sleep. And you talk about phones and technology and other things. We probably are having the same sort of social and cultural change that has, or environmental change, the environment in which children are growing up or adults are living in, a high stress, less active, less conducive to eating well and more stressful. And so actually, is it part of the same sort of, the end results may be different, but sometimes coexisting, mental health and obesity, we talked about it, but the factors, the wider factors, there's a lot of overlap within them, play, all of that, it would address both, is what I'm trying to say.
Thank you, Rachel. That's a good question, and I'm going to leave that hanging there, Richard. And we are 3 minutes over. Erin, I'm going to allow you to make a very quick comment on that.
Thank you very much. Voluntary sector, I think, was going to be my point. So it was really good to see the full scope work in there, hanging in the walls of Edinburgh, if anyone wants to come see the artwork from that. But actually, I know full scope is struggling for funding to keep that work going and keep that children's focus. I know quite a few of the voluntary orgs in that space are really struggling for funding. So I think there's something for us about how we bring that into the kind of strategic commissioning conversation. And then, the second point was just around those children who sit on a waiting list for a long time and then become adults before they're picked up in the children's side of the system, and just how we keep that in mind.
Again, very good questions. Thank you, Sally. Thank you, Richard. I know how much work has gone to prepare this. We will move now to the decision, which is the Cambridgeshire and Peterborough Health and Wellbeing Board Integrated Care Partnership is asked to approve the publication of Cambridgeshire's Annual Director of Public Health Report 2026 and to endorse the recommendations in the report, which are reproduced in section 3.1. Are we all in agreement? Thank you. It's noted. Yes, everybody.
Yeah, noted agreement. Thank you.
Thank you very much. Item 7 is the Health and Wellbeing Board and ICP Governance and Membership update. This item can be found on pages 243 to 250 of the agenda. Sally Cartwright, Director of Public Health for Cambridge County Council, will introduce the report.
Yes, thank you. So Kate Parker has tabled this report, but in her absence today, I am presenting it on her behalf. So it's relatively straightforward in terms of some outline changes that are required to the Constitution to remove the arrangement where the Health and Wellbeing Board and ICP had joint sharing responsibilities. So the chairing will remain shared between Peterborough City Council and Cambridgeshire County Council as a statutory committee of upper tier local authorities. So that's the main constitutional and structural change. And then we've also added in an update on the Health and Wellbeing Board development session that was held recently, because a key element of that was around how do we really, against all the changes and the increased focus on neighbourhood health through the work of the 10-year plan and ensuring that we get the 3 shifts, as well as maintaining the strategic approach across the health and wellbeing strategy that we've previously agreed. Against that backdrop of all those changes, how do we really maintain the governance and strength of the role of the Health and Wellbeing Board? So there were some key themes and recommendations that came out of the development session that it was opportune to highlight through this report and to make sure that there's ongoing visibility of those discussions at the development session, and that we're highlighting how that's starting to shape and the thinking that those discussions could lead to in terms of actions. So proposing that a working group develops those actions into some key areas of development to make sure that this board is as effective as it can be, so that we set up a working group, work that up in terms of some key actions and bring that back to subsequent meeting.
Thank you, Sally. Any comments or questions? All clear? Yeah. And the recommendations are, the themes for discussion were very clearly set out in the development session. The Cambridgeshire and Peterborough Health and Wellbeing Board and ICP is asked to amend the wording of the joint Cambridgeshire and Peterborough Health and Wellbeing Board Integrated Care Partnership terms of reference to remove the Integrated Care Partnership role within the rotating chair arrangements and reflect a revised model whereby Cambridgeshire County Council and Peterborough City Council each nominate a co-chair, with meetings chaired on a rotating basis between the two authorities. B, to endorse the proposed revisions to the terms of reference and to recommend approval to be followed through the relevant council's governance processes. And C, to review the early report from the development session with regards to strengthening the board role and governance, and endorse the proposal that a working group develop actions based on the feedback. Are we content to agree to these recommendations? Or? Perfect, fantastic. So,
thank you very much. Noted that the recommendations have been agreed.
We move to the last item, which is item 8 of the agenda plan. Is the agenda plan. This item can be found in pages 251 to 254 of the agenda. Ian Green, Public Health Service Manager of Peterborough City Council, will introduce the plan.
Yes, thank you, Chair. So this hopefully will be a quick item. So this is the forward plan for the next couple of meetings. You'll see that the next meeting is in October. It'll be hosted by Cambridgeshire, so it'll be in Alconbury. It's a very full agenda, so really it's comments on content of the forward plan, any changes or additions or omissions at this stage. But I'll take it as the paper is read. Thank you, Chair.
Thank you very much, Ian. Questions or comments with the agenda plan? No? Sally?
Only that I, in the last paper, proposed that it will only be brief, but a brief paper comes back on the roles and responsibilities and governance, and I don't think that's in there, so that's another item to try and squeeze in. But it will only be a short one, I think.
Okay, so we add that to the plan, Ian?
Ian's will pick that up, but yeah, I've got it noted, yeah, as an action.
Excellent. Right, and then Graham.
Just in the interest of time, I was wondering if the learning disability JSNA and the CYP mental health system issue pushed back to, and the priority for deep dive can be pushed back to January, just in the interest of managing the agenda.
So you mean the deadline for the draft report?
No, I mean that there are some of those from the priority for health and well-being ICB strategy, which is the mental health and the learning disability, if it can be moved to January, because in the interest of managing the agenda in October.
So I was just going to move a couple of these items
Okay,
to January.
we will. Thank you, Raj. Yeah, Graham?
I hate to mention this, but we were expecting an announcement from the Minister about local government reorganisation yesterday. That hasn't come. It's now due in the autumn. I just wonder whether there was something about the implications for this board that we should be considering when that announcement is finally made, which might then be in January.
It might be January because this is for the 2nd of October. I don't think that it's going to be on time, and who knows whether they delay that, in October, and then we move on to whatever.
Just to quickly say, so we've been told in respect of the LGR announcement by the Secretary of State, and okay, there could be some changes in the cabinet reshuffle that would get an announcement not before the 1st of September and hopefully not later than the end of October, so anywhere in between. I don't think there's any direct implications, in truth, to this board and its functions. Obviously, there is the ongoing uncertainty in respect of LGR, but I don't think in terms of the sort of practical and strategic sort of arrangements in the short term that there are any impact. So I think we can sort of continue to progress with the work we're doing in a way that isn't too affected. Not in the short term, anyway.
John?
So specifically for the forward planner, I think at the next meeting we're going to be looking at the neighbourhood health plan. We have had a number of development sessions where we've confirmed our priorities, frailty, on a number of occasions. I think it'd be worth us thinking about, beyond those plans that we look at in October, perhaps in January, what are we specifically proposing to do around frailty as a Health and Wellbeing Board? What does that mean in terms of commissioning and provision of those services, and what do we expect to be able to track into next year as an outcome of those activities would be most welcome.
Sally?
Thank you, John. And I think that also, I absolutely agree that that would be useful. We also just need to consider, as it progresses, and a shame Pam's stepped away briefly, around what if that discussion goes to the Neighbourhood Delivery Committee and what comes here, and how do we align those two conversations. But I think we can give that a bit of thought outside of the meeting and review what comes here versus there. But I agree that would be useful to have an item on that. I also just wanted to endorse Raj's point on the bits that maybe need to get moved to January, and actually learning disability GSNA is also down for January, so I think that's probably an error anyway, so that one can come out for October. And then I think in light of the children and young people's mental health discussion as part of the DPH report, I think bringing all of that to January would be helpful, and then that frees up more time for discussion on the neighbourhood health plans, and then just one of the priorities in terms of the health and wellbeing strategy for October.
Okay, that is all noted. Sounds all right, John. Any other suggestions to add to the agenda plan? No? Good. If there are not any further comments, then we can approve this and note that as.
Thank you. Approved and noted.
Thank you very much. Yes, thank you everybody for your attendance, and the meeting is now closed.